Yeah, so the talk today is going to be about robotic total hip for specifically developmental dysplasia of the hip. I think what Dr. Gurardi was saying is extremely valid. You don't need a robot to do the surgeries, but there are certain indications, partial knee being one of them, where I think robot provides tremendous help in terms of surgical planning and efficiency intraoperatively. And I think for me, severe developmental dysplasia, we're talking about CRO 3 or above, really CRO 4, I think this gives a tremendous amount of help in making sure your acetabular component position is ideal. As we saw on first day of surgery, taking a girdle stone down and trying to find the acetabulum, in a developmental dysplasia case, it's a similar problem, especially CRO 4 where it's very undeveloped. It is very difficult sometimes to identify because there's no normal landmarks and you don't know how much bone stock there is. Preoperative CT scanning and planning helps tremendously with that. So none of the disclosures are relevant. So we all know dysplasia is a continuum. We're talking, in this case about severely dysplastic, chronically or congenitally dislocated hips, grade 4 CRO classification. Manual THA for DDH, especially in CRO 4, which is a high dislocation, is technically very challenging. Identifying acetabulum is difficult. Appropriate sizing of the components and then trying to get ideal version and inclination can be challenging because there's not a lot of bone. And some of the complications that have been identified with DDH cases, especially with a high hip center, which sometimes you have to make a compromise intraoperatively because you don't know where the bone stock is, or are worried about lengthening, can result in early loosening and then dislocation because of improper implant positioning. So this is a case, 55-year-old, shortened leg since birth, high hip dislocation, CRO 4, and then pain became worse for the last 5 to 10 years, and she couldn't take the pain anymore and wanted something done. This is, it's very rare for us to see these cases in the US. I mean, probably one per year. Again, dysplasia is very early identified. Patients are treated, from newborn nursery itself. This patient is a Hispanic patient coming from Central America, so those are usually some of the patients that we see have these types of really bad dysplasia. So plan was robotic guided acetabular cup placement and then followed by subtrochanteric shortening osteotomy. Obviously, there's no robotic guidance for that at this point. She was approximately 6 to 7 centimeters short. So lengthening was planned approximately 2 to 3 centimeters and then shortening 3 to 4 centimeters. The actual shortening amount is always determined intraoperatively once you do a provisional reduction to make sure, like Dr. Bose was mentioning, that you do not over-resect, which is a tough problem to solve. Important thing to remember in shortening osteotomies or DDH patients that you're lengthening, greater than 2 centimeters of lengthening increases risk of sciatic nerve palsy. 4 centimeters of lengthening is very high risk, about 5 to 15% depending on the literature you're reading. That's why subtroch osteotomy shortening acutely is highly recommended, so you don't lengthen that nerve that much. So this is just the preoperative x-rays that we have seen. Luckily for her, it looked like she had decent bone stock around the what should be the true acetabulum. She never had an acetabulum in that region. She basically had a pseudo-acetabulum her entire life, like you can see there. On the femoral side, again, luckily she had normal canals. The greater trochanteric region appeared okay. So, I didn't feel like I had to do anything unusual or special. One of the considerations, again, is bringing this hip down. You're going to need to do extensive releases. One of the tricks sometimes, if it has to be done, is maybe a iliopsoas lengthening or release. In this case, I didn't have to do it, but that's something I would also think about before going into the surgery. So this is the most helpful part where you have this preoperative CT-based planning. You can see exactly where the leg length discrepancy, how much it is. Comparing center of rotation of femoral head on the contralateral side, you use that as your baseline and compare that to the current center of rotation. And here you can see that it shows about 57 millimeters shorter. Again, this gives you a 3D view. You can evaluate where her pseudoacetabulum is. She was basically sitting up in the ilium, and it looked like even that kind of moved maybe in the recent times because there's a big hole up there. Maybe that's what's causing her pain. I'm not sure. And then cup sizing, head sizing. So you will, before you even start the surgery, you're able to determine what the cup sizing is going to be, and that is very helpful. So this is the beauty of the robotic planning. So I know what is my ideal version or inclination that I want. I will put that into the computer, and then I will try to find the most ideal location for that, given the bone stock that's available. And I know Dr. Bose was mentioning, you don't necessarily want to medialize all the way. Sometimes in these small, underformed acetabular walls, with the robotics, it gives you an extreme degree of precision to put it where you're just touching the wall or maybe just breaching, but not too much where you lose any bony stability or contact. And you can see here with my plan, we're well tucked in, more than 60% of bone coverage, 40 to 45% of uncoverage is okay. There's a little bit of uncoverage posteriorly, which I'm not too worried about. Got very good bony contact, rim fit otherwise. And here you can see how I've planned just a touch of breach on the medial wall where that gave me the most ideal coverage, but I'm not really worried about going through the medial wall and causing any protrusio. And I can reproduce this intraoperatively to extremely high degree of precision. And then this is CT views that'll again show you the same thing where I'm just at the medial wall, good coverage. And then, technically, once I reduce the hip, this is what my leg length should be. Obviously, this is an extreme amount of lengthening. We do a subtrochanteric osteotomy after. Advantage intraoperatively, single ream. I mean, the amount of time you spend in a conventional case with this of taking care to find the acetabulum and then slowly reaming and making sure you're at the right place. This makes it incredibly efficient, and then with a single ream. So once the reaming is done, it tells you the depth. You know exactly how far you need to go. Once you're at that level, you're done. I don't really use the femoral side of things. I don't think it's a huge help in robotic hips yet, but hopefully in the future they're able to really allow us to dial in the anteversion of the stem, which hopefully things are coming down the pipeline that'll help us do that. The other huge advantage, I think, of a robotically done surgery like this is navigation of the screws intraoperatively. The current software does not truly allow you to navigate, but there is software coming, the new release, probably within 4 to 5 months, where you can truly navigate screws. It will show you which column of bone you're putting the screws down. It'll also show you the screw length. So before you even go into surgery, you know where you're putting the screws, where the holes are going to be in the cup, and how much that length is going to be. Significantly reducing intraoperative time, worry about breaching cortices, worrying about neurovascular compromise. So in this case, I tried to do a poor man's navigation where you take a probe and you place it where I want my screw, and then you can put up your CT scans in 3D plane, and you basically say, in this trajectory, I have good bone in the back, so you can try to get a bigger screw. It's often very difficult to get x-rays for these, because you're in a lateral position, it's cumbersome. So I think this is a nice help that's available. Really shortly about subtrochanteric osteotomy, I know we've seen one. Important steps: get the cup done first, put a trial liner in. You make your initial proximal transverse osteotomy, 1.5 to 2 centimeters distal to the lesser troch is your general landmark. Then you prepare the proximal part of the bone initially with the stem, and you provisionally reduce. So you reduce the proximal part, and you see how much overlap there is between the proximal fragment and the distal fragment. That's where you're going to mark your second or distal limb. And once you have done that, you're much more confident that you're taking the right amount. And then you finally reduce everything together, prepare the distal and proximal fragments together, and get a full reduction. So these are the final post-operative x-rays for the case I did. I had really, really excellent stability, rim fit with just one reamer and putting the cup in. I didn't even really feel like I needed screws, but since this is a smaller cup dysplastic patient, I didn't want to take any chances. She was also relatively young and active. So we put 3 screws in the superior column and then 1 off-axis screw. And I didn't really spend too much time worrying about getting a long screw down the pubis or ischium because we had excellent bone fit. This is 6 months post-op. Her osteotomy is appearing to heal well, and she's doing good. I did put a derotational plate Like I said, we don't do too many of the shortening osteotomies and SROM, so I wanted to make sure I didn't have any problems with derotation, but she's doing very well now. She does have IT band syndrome just from the acute lengthening. Other than that, she's walking very well, back to doing her job, and she's very happy. So really quickly, advantages: preoperative planning, cup sizing, your positioning of the cup is going to be much more accurate, and then anatomic hip center recreation, which is extremely important in high dislocations, because if you do a high hip center, there's higher risk of loosening and dislocation. And then intraoperative execution, so it makes it more efficient. You're less stressed as a surgeon to ensure you're not damaging any neurovascular structures, and then navigation of screws. Hopefully with the new softwares that are coming out, that'll be even easier. Thank you.